Hello everyone, myself Dr. Parth, and sorry I am not able to post the video since long time, but today I am back with a new video on testicular tumor. So this is a very important topic from the male genital system. So let's begin with testicular tumor. Now before we understand the testicular tumor, you should be familiar with the normal histology of the testis. Then and then you can understand the testicular tumors in a detail, and then you can understand the morphology. So first of all, histologist begins with tunica albuginea, which is a thick connective tissue covering of the testis. It's a covering of testis. So this is the tunica albuginea, that is the connective tissue covering of testis. Now beneath the tunica albuginea, there is a vascular layer and made up of loose connective tissue that is known as a tunica vasculosa. So this particular portion is tunica vasculosa, right? So we have a tunica albuginea and vasculosa. Now, there are very thin fibrous septa that divide the testes into the various lobules, and each lobule of the testis contains 3 to 4 seminiferous tubule. So here you can see that this fibrous septa dividing the testis into this lobule, and in this lobule we can see a very various number of seminiferous tubules, right? So this elongated structure is the seminiferous tubule. All right. And within the seminiferous tubule, we all know that in your first professional year of medical school, you might have learned about the seminiferous tubule histology, that it is lined by germinal epithelium. It is lined by stratified epithelium that is known as germinal epithelium, and it is containing a spermatogonic cells, particularly primary, secondary spermatogonia and developed sperm, right? So the sperms are within the seminiferous tubule. These are the sperms, right? They line the seminiferous tubule. They are within the seminiferous tubule. Alright. Now, within the seminiferous tubule, there is a presence of one supportive cell. The name is Sertoli cell. They are the supportive cells within the tubules. They provide the nutrition to the developing sperm. So the developing sperm will get a nutrition from the Sertoli cells. And they also do the function of phagocytosis, means they remove the tissue debris, they remove the bacteria whenever needed, and they secrete the hormones like that of anti-mullerian hormone, and they secrete inhibin. So that is about the Sertoli cell that line the seminiferous tubule. And the space between the tubule made up of connective tissue and blood vessel, that is known as the interstitium. So space between this tubule is known as the interstitium. This is the interstitium. Follow this laser pointer. This is the interstitium between the tubules. And if you observe carefully, the interstitium is containing lots of these eosinophilic cytoplasm containing cells. See, these cells having eosinophilic cytoplasm and well-defined border. These are nothing but an interstitial cell of leyding. An interstitial cell of leyding is having the function of secretion of male sex hormone, that is the testosterone. Alright. So that was about the testicular histology. Now you can understand the testicular tumor in the detail, and you can understand the morphology. So at the nutshell, in the testis histology, we have a tunica albuginea, beneath which there is a presence of vasculosa. Fibrous septa divide the testis into various lobules. The lobule contains seminiferous tubule, and within seminiferous tubule there is a developing sperms, and we have a supportive cell, that is the Sertoli cell. In the interstitium, there is a presence of cells with having dense eosinophilic cytoplasm, that are the interstitial cell of leyding. So we can say that Sertoli cell and leyding cells are the sex cord-stromal cells, right? While sperms and germinal epithelium are germinal epithelial cells. Alright. Now, what is the pathological classification of testicular tumor? Now you can understand the classification of testicular tumor. So the tumor could arise from the germ cells, that is known as a germ cell tumor, means they can arise from spermatogonia or sperms, right? They arise from germ cell, then it is germ cell tumor. And if they are derived from sex cord-stromal, then it is known as sex cord-stromal tumor. So first, germ cell tumor again divided into two categories. First category, that is derived from germ cell tumor, that is derived from germ cell neoplasia in situ, or germ cell tumor unrelated to germ cell neoplasia in situ. Now what is germ cell neoplasia in situ? Means the tumor is within the tubules, right? The tumor cells are within the tubule, and they doesn't invade the stroma. They doesn't invade the surrounding stroma, means they doesn't invade the interstitium. That is tubular germ cell neoplasia in situ, and that is the preliminary tumor from which the invasive germ cell tumor will arise. So we will see how the germ cell tumor invade the stroma from germ cell neoplasia in situ. So that particular category includes seminoma, Yolk Sac tumor, Choriocarcinoma, and the teratoma. Uh, the tumor that is unrelated to in situ, that could be spermatocytic tumor, teratoma particularly prepubertal type, and Yolk Sac tumor of prepubertal type. See, this is very important. Teratoma prepubertal means that is arising before puberty, and Yolk Sac tumor before puberty are included in a category that is unrelated to germ cell neoplasia in situ. But the post-pubertal Yolk Sac tumor and the post-pubertal teratoma will be included in a category that is derived from germ cell neoplasia in situ. Alright, so at the nutshell, which are the germ cell tumors? So that is the seminoma, embryonal tumor, embryonal carcinoma, Yolk Sac tumor, choriocarcinoma, teratoma, and spermatocytic tumor. These are the germ cell tumors. While which are the sex cord stromal tumor? So the sex cord stromal tumor that is derived from sex cord stromal cells, that are the Sertoli cells and leyding cell. Now the tumor that contain both germ cells as well as the sex cord stromal tumor, both these category, germ cell as well as sex cord stromal tumor, that is the gonadoblastoma. So basically we have a three category: germ cell tumor, sex cord stromal tumor, and gonadoblastoma. We will discuss in detail of each tumor one by one. So first, let's begin with etiopathogenesis. Why testicular tumor develop and what is the mechanism for the development? Now this is very interesting scenario that is given in the Robbins book. They have written the example that incidence of the testicular germ cell tumor in Finland is about 2 times lower than the Swedish population. But in a study, the scientists observed that second generation Finnish immigrants, means those immigrants, those individuals that immigrated from the Finland to the Sweden, they have a high tumor incidence. They have an incidence similar to like that of Swedish population. So that clearly shows that environmental factor plays a role in the development of testicular tumor. So there exists a geographical variation in the incidence of testicular tumor because the environmental factor affecting the testicular tumor. We will see in detail later on in the slide that how testicular tumor develop because of environmental factor. One of the important risk factor for the development of testicular tumor is cryptorchidism, most important risk factor. 10% testicular germ cell tumor are associated with the cryptorchidism, and reason is that it could be due to high temperature in the abdomen and inguinal region compared to the scrotum. What is cryptorchidism? Cryptorchidism means testes will not reach up to the scrotum, and during the development, they will stuck to the abdomen or inguinal region. They should reach to the scrotum. In the scrotum, temperature is very low, and so testis is protected. But if their growth is arrested in abdomen or inguinal region, then high temperature could be the reason for development of testicular tumor. So cryptorchidism is one of the important risk factor. Another important risk factor is testicular dysgenesis syndrome. Means the patient is having cryptorchidism, hypospadiasis, androgen insensitivity, and poor sperm quality. So that could put you a risk for the development of testicular tumor. It is related to the in utero exposure to the pesticides and estrogen. Now, what is hypospadiasis? The hypospadiasis means urethral opening is not in the middle, but the opening is underneath the penis. The opening could be distal, mid shaft, penoscrotal, or perianal. But in but in fact, it is not in the middle. It is underneath the penis. That is hypospadiasis, abnormal urethral opening. All right. Genetic predisposition could be responsible for development of testicular tumor, particularly isochromosome P12. Now, what is isochromosome? So usually the chromosome, divide vertically. But here instead of vertical, there will be transverse separation of the chromosome. And because of transverse separation, we have a 2 short arm and 2 long arm. So that is known as a isochromosome. And if it affect chromosome number 12, then you are at a risk of development of testicular tumor. Klinefelter syndrome, obviously well-known risk factor for the development of testicular tumor. And here the chances of development of testicular tumor is 50 times more. And here the development is of mediastinal germ cell tumor rather than testicular tumor. Mutation in the c-KIT could be responsible for development of testicular tumor. We will see in the next slide that how mutation in KIT will lead to testicular tumor development. Alright. So this is a very important diagram from the Robbins book that shows the saline, environmental, and genetic risk factor and they shows the importance of epigenetic alteration and genetic alteration that lead to subsequent development of germ cell tumor, how it develop and how it progress. So see, basically because of cryptorchidism, because of other environmental exposure, because of other risk factors, because of mutation in KIT, primordial germ cell will stop the differentiation. They will not develop in a sperm. The differentiation will be arrested. And if there is, and that's because of environmental factor, genetic factor, and epigenetic modification. What is epigenetic modification means? The examples could be DNA methylation, like that of condition, that is epigenetic alteration means the events that lead to DNA methylation, histone modification, that are the epigenetic alteration. So differentiation is arrested. Now if there is additional hit in the form of KIT mutation, then there could be development of germ cell neoplasia in situ. Here the tumor cell doesn't invade the stroma, right? It is a in situ. So the prognosis is good. They have not infiltrated the stroma. They are not the invasive tumor. And the reason is KIT mutation. Now what is KIT? What is c-KIT? So KIT is a proto-oncogene, means that is required for the normal growth of a cell. Proto-oncogene, we know that proto-oncogenes are the normal genes that are required for the growth, of cell, for the cell proliferation. The KIT, the proto-oncogenes are needed, and one of the proto-oncogene is KIT. But if they are overexpressed, if they are mutated, then they are converted into oncogene, and that could lead to aberrant development of cell proliferation. There will be more cell proliferation if proto-oncogene convert into oncogene, and in the form of KIT overexpression or KIT mutation. So that will lead to germ cell neoplasia inside. And if there is other late event in your pubertal life, if there is isochromosome 12p development, then invasive germ cell tumor could be developed. So this is the role of certain risk factor that ultimately lead to development of invasive germ cell tumors. So what is germ cell neoplasia in situ or intratubular germ cell neoplasia? So it is a pre-invasive form. 50 to 70% testicular tumor develop from this germ cell neoplasia in situ. So initially, the patient will have pre-invasive tumor for many years, for might be up to 5 to 7 years, and gradually they develop invasive tumor. Grossly, there will be only patchy area over the testes. There will be no growth. The tumor cells are usually larger than spermatogonia if you observe histopathologically. They have a well-distinct cell border, clear vacuolated cytoplasm, which contain the glycogen. That is similar to Seminoma morphology, which we will see later on in this slide. There could be positivity for OCT34 nanog or PLAP positivity. Now let's begin with first testicular tumor, that is the seminoma. So we will begin with first testicular tumor, that is seminoma. Now it is one of the most common germ cell tumor. Around 50% germ cell tumor are seminoma. The common age group is 30 to 40 years. Female counterpart in the ovary is known as a dysgerminoma. And origin is, as we know, undifferentiated germ cell. It arises from the undifferentiated germ cell spermatogonia. And the isochromosome 12p and the KIT mutation are mainly involved in the development of seminoma type of tumor. Alright. So why we need to diagnose this, whether the testicular tumor is seminomatous tumor or non-seminomatous tumor? Because in the seminomatous tumor, testicular tumor, the prognosis is very good, while that of non-seminomatous testicular tumor, the prognosis is poor. So that's why we need to differentiate between the seminomatous and non-seminomatous tumors. The prognosis is different in both the category. Alright. So how the seminoma type of testicular tumor present grossly? Gross appearance of naked eye. Morphology include two things: gross appearance as well as microscopic appearance of tissue after tissue processing. So what is the gross appearance? So gross appearance is like that of the tumor is bulky, solid, rubbery form and bosselated appearance. So see, this is the testicular tumor of seminoma category. It's a very solid, bulky, rubbery form. The size is very large, 2 to 6 centimeter, and you won't believe sometimes the testes could enlarge 10 times to that of normal size. 10 times testicular enlargement could be seen in a seminoma. And on a cut surface, it shows a gray-white yellow lobulated appearance. And if you observe carefully, here you can see that tumor is sharply demarcated from the normal testes. Here it is sharply demarcated from the adjoining normal testes. Tunica albuginea is usually not penetrated. Now this sentence is very important. Tunica albuginea usually not penetrated means overall the prognosis is very good in seminoma tumor. What is the microscopic appearance of seminoma? If you process the tissue, if you take the sections from this tumor, you process the tissue, cut in a microtome and stain with He stain, then how it look microscopically in a microscope. So photomicrograph shows a seeds, nest, cord type of patterns. And the seminoma cells are uniform and they resemble like that of spermatogonia. It is very well differentiated. Now, this is the diagram that shows the photomicrograph of seminoma. Here you can see that fibrous septa divide the testes into various lobules, right? And here within the nest, lobule or nesting pattern, here in the nest, you can see that cells having large vesicular nucleus, open chromatin and prominent nucleoli. This blue color dot is nucleoli. So there is an open chromatin, vesicular nucleus and prominent nucleoli, right? Here it is shown as a red color dot. So prominent nucleoli is present, vesicular nucleus, open chromatin, and if you observe carefully, you can see that the cell border is very well defined. Here you can see that well defined cell border. So these are the cells. The seminoma, the appearance of seminoma is that the cells is large, round, polyhedral with well-defined, well-distinct cell border. And if you observe carefully, the cytoplasm is clear. Here also you can see that cytoplasm is clear. So cytoplasm is clear, watery because of the presence of glycogen. It could be pass positive. It shows the pass positivity as a pink color. So due to the presence of glycogen, it shows the clearing, right? Alright, and the nucleus is centrally placed, vesicular nucleus, granular chromatin. Again, one important feature, if you observe carefully, the fibrous septa is infiltrated by a lymphocytes and plasma cell. They are infiltrated by a chronic inflammatory cell. These are the lymphocytes with scanty cytoplasm, right? Here also you can see a lymphocytes. So this is the photomicrographic appearance of seminoma. It is very well differentiated tumor, right? It is not aggressive tumor. Well differentiated means the differentiation is not lost, right? The solid cells are less. All right, again this shows the fibrous septa that divide the testis into lobular or nesting pattern, the cells having clear cytoplasm. So this is again the photomicrograph of seminoma. All right, what is the immunohistochemistry of seminoma, IHC? So if you do the IHC, then it could be positive for PLAP or KIT. OC3, SELA4 could be positive. This is the cytoplasmic positivity, while this one is the nuclear positivity, OC3 and SALL4. So what is the prognosis in a seminoma? So in the seminoma, prognosis is very good because they are extremely radiosensitive. Tumor will dissolute after radiotherapy. It metastasizes mainly to the regional lymph node. It doesn't metastasize to the various organs through the blood. It metastasizes only to the regional lymph node, even if it metastasizes. So prognosis is overall good. Alright. So that is about the seminoma, well differentiated tumor. Now we move to the second type of testicular tumor, that is embryonal carcinoma, which is a very aggressive tumor as compared to seminoma. So the prognosis is poor, age group is 20 to 30 and they resemble like that of embryonic stem cell. That's why name given is embryonal carcinoma. They are very aggressive. The size is small as compared to seminoma. The size will be small but very aggressive tumor. Now, what is aggressiveness? Why I am telling that it is aggressive? Aggressiveness means the differentiation of the tissue will be lost, and there will be high degree of anaplasia. Means there is a high degree of high NC ratio. Features of anaplasia will be more. There will be more mitosis. There will be more hyperchromatism. So it is aggressive tumor. What is gross appearance? So grossly it shows the variegated appearance. What is variegated appearance? Variegated appearance means that is shown in this leaf. Different zones of color present in this leaf. So that is variegated appearance. And why such appearance is seen in this tumor? Because we know that malignant tumor usually grossly shows necrosis and hemorrhage. So because of the presence of necrosis and hemorrhage, as it is aggressive tumor, because of necrosis and hemorrhage, there will be variegated appearance. And as it is aggressive tumor, it will penetrate the tunica albuginea, it can penetrate the epidermis, spermatic cord, and even with the blood, they can spread to the other organ as well. That is in contrast feature to that of seminoma, which usually doesn't penetrate the albuginea. But here it penetrates the albuginea and it can metastasize. It is very aggressive tumor. Here you can see a hemorrhagic mass. So what will be the microscopic appearance? The pattern could be solid seed, nest, papillary, tubular or glandular. And as it is highly aggressive tumor, there will be marked degree of pleomorphism. Pleomorphism means variation in the size and shape of nucleus and cell. There will be more abnormal mitosis. There will be indistinct cell membrane. There will be more anaplasia. There will be prominent nucleoli and even tumor giant cell can be seen. So all the high grade features of anaplasia will be present in embryonal carcinoma. If you are not familiar with what is anaplasia, then see my video on nomenclature of tumor first. So your fundamental will be clear about the anaplasia. IHC will be positive for cytokeratin and CD30. So again, this is photomicrograph of embryonal carcinoma. It shows the large vesicular nucleus, open chromatin, prominent nucleoli, and you can see that the tumor is not well differentiated. They are poorly differentiated. They are highly invasive. They have infiltrated the stroma, and the cell border is also not distinct. So this is the embryonal carcinoma. Here it shows the papillary pattern. Now third category of testicular tumor is Yolk Sac tumor. So Yolk Sac tumor grossly present as a soft yellow-white and sometimes mucoid area. This is very important differentiating point. Sometimes mucoid area or yellow-white area can be seen in a Yolk Sac tumor grossly by naked eye appearance, right? And necrosis and hemorrhage obviously present because necrosis and hemorrhage is a feature of malignancy. Malignant tumor usually shows necrosis and hemorrhage. What is microscopic pattern? So microscopically, Yolk Sac tumor could present as a reticular network, papillary pattern, tubular pattern, or solid seed pattern. These are the different patterns that can be seen. Very importantly, in a Yolk Sac tumor, Schiller-Dewar body is seen. So what is Schiller-Dewar body? So Schiller-Dewar body means it is a glomerulus-like structure, means centrally there is a presence of blood vessel that is enveloped by a tumor cell within a space that also lined by a tumor cell. So there is a double layer of tumor cell. In between there is a place and centrally there will be blood vessel. So it resembles like that of endodermal sinus or Yolk Sac, and that's why this tumor is known as Yolk Sac tumor. So this is the Schiller-Dewar body. You can see a central capillary that is lined by a tumor cells, visceral and parietal layers. So that is a Schiller-Dewar body that is characteristically seen in Yolk Sac tumor. And obviously the features of anaplasia will be seen, means high NC ratio, pleomorphism, hyperchromatism, prominent nucleoli will always seen in malignant tumor. So that features will be present. And here you can see that in this photomicrograph, microcystic reticular pattern is seen. So this is the Yolk Sac tumor presenting with microcystic, these are the cysts, right? Microcystic reticular pattern. Alright. Fourth category of testicular tumor. Fourth one is teratoma. So grossly, it's large gray white mass with enlarging testes, and microscopically variegated appearance could be seen. Honeycomb areas could be seen with focus of cartilage and bone. Now this is very important. Cartilage and bone can be seen. So what is teratoma? Teratoma means the tumor that composed of tissue that is derived from more than one germ cell layer. Now, if you see all other tumors in our body, they arise from the one germ cell, not more than one germ cell. Here, you could have the tissue from the ectoderm, that is skin. You could have tissue from the mesoderm. You could have tissue from the endoderm. Means you can have GI epithelium, respiratory epithelium. You could have neural tissue. You could have bone, cartilage, all type of tissue in a one tumor. That's because they are arising from more than one germ cell layer, and that type of tumor is known as teratoma. And classically, it shows the elevated HCG or AFP that is found in 50% case. These are the tumor marker. Tumor marker means they are the substance that is released in a blood from a particular tumor. So that can be investigated from blood. 45% mixed germ cell tumor composed of teratoma. So this is the teratoma. It contains intestinal epithelium, here cartilage. So it contains variety of tissue. See, it can contain cartilage, smooth muscle, squamous epithelium, transitional epithelium, respiratory GI epithelium, mucous gland, neural tissue, fat, bone. All type of tissue can be present because they are arising from more than one germ cell layer. They can arise either from ectoderm, endoderm, or mesoderm. They could contain elements from all these germ cell layers. That's why it is a teratoma, right? All right. So that was about the teratoma. Now, choriocarcinoma, fifth category, fifth tumor, testicular tumor, important tumor is choriocarcinoma. This particular tumor is very small in size, but don't neglect it. It shows the necrosis and hemorrhage, and it is a very aggressive tumor. Prognosis is very poor. So this is the female counterpart also could be seen in a placenta. So the morphology will be similar. In a photomicrograph, they will show syncytiotropoblast and cytotrophoblast that is present in placenta. What is syncytiotropoblast? Syncytiotropoblast means they are the large cell with bizarre nucleus and abundant vacuolated cytoplasm. See, this is the syncytiotropoblast, multinucleated cell. This is the syncytiotropoblast, large cell and multinucleated, right? While these are the cytotrophoblast. Cytotrophoblast is a polyhedral cell with clear cytoplasm and hyperchromatic nucleus. They have a well-defined cell border usually. So cytotrophoblast and syncytotrophoblast could be present in case of an choriocarcinoma. That is indicative of choriocarcinoma. And HCG and keratin is positive as a tumor marker. So see, this is a choriocarcinoma containing cytotrophoblast, right? This is a cytotrophoblast, clear cytoplasm. While this is the syncytotrophoblast. Again, this is cytotrophoblast. So syncytio and cytotrophoblast seen in choriocarcinoma. Alright. Now sixth category of tumor is Sertoli cell tumor. Now we will discuss about the sex cord-stromal tumor. So first, let's discuss about the Sertoli cell tumor. So these neoplasms appear as a firm nodule and gray-white appearance. Histologically, tumor cell arranged in a well-distinguished trabecula, that tend to form a cord-like structure and the tubules. So tubular-like structures will be formed, cord-like structures. That's because they are arising from the Sertoli cell. And most of the Sertoli cells are usually benign, but approximately 10% could be malignant, or else they will be benign. And most of the Sertoli cell tumors are hormonally silent. This is very important. They doesn't secrete any hormone, right? They present only as a testicular mass. They are benign tumor, and photomicrograph here shows a clear cytoplasm. Sertoli tubules can be seen. It can present in a variety of ways. Alright. This is the example of leyding cell tumor. Grossly it shows a brown color. And they are hormonally active. Sertoli cell tumor are not hormonally active, but this is the hormonally active means they will secrete a hormone like that of estrogen, steroid, or androgen. So male patient could present with breast enlargement that is known as a gynecomastia. So patient will present with testicular swelling as well as gynecomastia, right? And leyding cell tumor is associated with Klinefelter syndrome, cryptorchidism, and hereditary leiomyomatosis, and sometimes with renal cell carcinoma as well, renal cell carcinoma syndrome. And 10% leyding cell tumor could be malignant. So this is the classical appearance of leyding cell tumor, because we know that leyding cells contain dark eosinophilic cytoplasm. The cytoplasm is eosinophilic. So these are the leyding cells, right? Leyding cell tumor. All right. Now, last category of testicular tumor is spermatocytic tumor. They are derived from post-pubertal life, so they are common in age group after 45. They are common in old age group, right? So they are developed from post-pubertal germ cell that undergoing spermatogenesis. Grossly, they present as a 3 to 5 centimeter size, pale, soft, and lobular to multinodular. Sometimes hemorrhage and mucoid cyst could be seen. Pattern could be diffused to multinodular in a microscopic. Now, what is important photomicrographic appearance of spermatocytic tumor? How it is diagnosed? So they are diagnosed by a tripartite cell, means they contain three type of cell: small, intermediate, and large cell. Small cell is like that of lymphocyte. They resemble secondary spermatocyte. Intermediate cells having granular chromatin, somewhat large in size and sometimes filamentous, elongated. While the large cell are usually giant cell, they are multinucleated, right? So these are the tripartite cell. This is the large giant cell, these are the intermediate size cell, and this is a small lymphocyte like cell. So all three categories, small, intermediate, and large size cell, tripartite cell, are present in spermatocytic tumor. Prognosis is very good. Alright, so that was about the gross and microscopic appearance of testicular tumor. Now, what would be the clinical feature? How the patient will present to you? So, in a clinic, the patient will complain painless testicular enlargement. Patient will say that, doctor, my testis is very much enlarged. Patient will felt dragging sensation in the testis. And if the testicular tumor already spread to the lymphatics, like that of periaortic, mediastinal, supraclavicular node, then it can lead to symptom accordingly. For example, abdominal pain, abdominal mass, if they infiltrate the node that is in the GI tract, if they invade hilar nodes or mediastinal node, then hemoptysis could be presentation. And sometimes urinary obstruction complaint is present if pelvic nodes or another suitable urinary tract nodes are involved. All right. Biopsy is contraindicated when patient present in this way. You will do the ultrasonography. You can go for other investigations, and if the testicular tumor is suspected, biopsy is contraindicated because there is a risk of tumor spillage if you do the biopsy with a needle. So biopsy is contraindicated. FNAC obviously contraindicated. The treatment is radical orchiectomy and then send it for histopathological examination. All right. Now, what is at the nutshell difference between the seminoma tumor and non-seminomatous tumor? Now, this table shows why it is important to diagnose the tumor, individual tumor. Because, the seminomatous tumor prognosis is good while non-seminomatous tumor prognosis is bad. What is the component of seminomatous tumor? In a seminomatous tumor, there is presence of only one histology, cell with clear cytoplasm. They will secrete only HCG in a 50% case. But non-seminomatous germ cell tumor can present with more than one histological type. Now, what is meaning of that? Meaning of that is that, in a non-seminomatous germ cell tumor, patient could present with combination of embryonal and Yolk Sac tumor. Patient could have more than one histology in the form of embryonal and Choriocarcinoma. Patient could have teratoma as well as Yolk Sac component. So multiple histological types could be present in a non-seminomatous germ cell tumor, and that's why they can secrete HCG, AAP, LDH, PLAP like that of tumor marker. We will see later on in the slide. Seminomatous tumor usually localized to the testes. They doesn't invade the tunica albuginea. They can only metastatize to lymph node. Even though they metastatize to the lymph node only, and they are usually in the stage 1. While non-seminomatous tumor can metastatize early, they can via blood, via hematogenous route, they can metastatize to the different organs. So they could be in a stage 2 and 3. That's why the prognosis is poor in a non-seminomatous tumor because it is in a higher stage. While if it is stage 1, then prognosis is good because in seminomatous the tumor is in stage 1, so prognosis is good. While here it is poor. Grossly, they are bosselated rubbery form appearance, seminoma, right? Necrosis, hemorrhage are absent. Less tendency to infiltrate tunica albuginea, spermatic cords, and scrotal sac. But non-seminomatous tumor, necrosis and hemorrhage is very common. They will infiltrate the tunica albuginea, even though they infiltrate epididymis, spermatic cord, and scrotal sac. So shape of testis could be distorted in a non-seminomatous tumor. Again, we need to differentiate these tumors, seminomatous and non-seminomatous, because the prognosis is different. And again, apart from behavior and prognosis, seminomatous tumor will show the response to the radiotherapy. They are radiosensitive, while non-seminomatous is radio resistance. They respond to chemotherapy only, right? They doesn't respond to radiotherapy. All right. So testicular tumor can spread via lymphatics or hematogenous route. And if via hematogenous route they spread to the lung, liver, brain and bone, then prognosis is poor, which is usually seen in non-seminomatous germ cell tumor. Which are the non-seminomatous germ cell tumor? Embryonal, Yolk Sac, teratoma or choriocarcinoma. And they will present in a combination. They will present as a more than one histological type usually. Alright. Now what is tumor marker? That is positive in testicular tumor. So tumor marker means, germ cell tumor secrete the hormones and various enzymes which can be detected in a blood. So in a blood, we can detect a substance that is released from the tumor. That is released from the tumor. So that can be detected in a blood, and they are known as a tumor marker. So what is the importance of detecting this substance in a blood? So obviously, it will be helpful in the evaluation of testicular mass. We can stage the testicular tumor, right? If the stage is more, then more tumor marker load will be seen. We can assess the tumor burden. We can monitor the response to therapy. Means after therapy, the marker level should be fall down. In a non-seminomatous germ cell tumor, more than 80% alpha-fetoprotein and HCG, human chorionic gonadotropin, will show the elevation, while AAP mainly produced in a Yolk Sac tumor. HCG mainly elevated in choriocarcinoma and in seminoma. So these are the type of tumor and tumor marker. In a seminoma, the detectable tumor marker is HCG usually, sometimes alkaline phosphatase. In a teratoma and teratocarcinoma, AFP, alpha-fetoprotein and HCG could be elevated. In a embryonal carcinoma, carcinoembryonic antigen elevated. In a Yolk Sac tumor, purely alpha fetoprotein will be elevated in a blood. While in a choriocarcinoma, there is a tremendous increase in beta HCG level. All right. All right. Now, let's see one or two MCQ. This type of MCQ can be asked when you are going to give a medical entrance exam. So 38-year-old man present with 10-month history of painless testicular mass. Physical examination reveals small nodule. See, the nodule is very small. It is not large. So we are not dealing with seminoma, very small nodule. So it could be non-seminomatous tumor. The mass cannot be trans-illuminated and appear solid on ultrasound. So it is having solid appearance, not mucoid. Right? Mucoid appearance is not present, only solid appearance. Testicular biopsy is shown in the image, right? Orchidectomy is done, and here tissue is processed. Section were taken, tissue is processed, and here it shows the photomicrographic appearance. It shows the multinucleated giant cell. See, this is a multinucleated giant cell that is seen. So it could derive from which type, which of the following cell type, right? So what is first, what is a probable diagnosis? Here we can see a lots of hemorrhage. It obviously it's a malignant tumor, it's a non-seminomatous tumor as the appearance is solid small nodule grossly, right? And here we can see a multinucleated giant cell. Here you can see a clearing of cytoplasm. So we are dealing, multinucleated cell usually always seen in choriocarcinoma. This is a syncytiotropoblast, right? Syncytiotropoblast. So syncytiotrophoblastic cells is seen. So answer is trophoblastic cell. During physical examination of newborn boy, the pediatrician noticed that urethral metastasis position on the lower side of penile sac. What is the appropriate diagnosis of this congenital birth defect? Means the urethral opening is lower side of the penis. That is known as a hypospartiasis. All right. See, this type of long question can be asked in your exam, as a long answer question. It can be asked like that of 32-year male complain of painless heaviness in a scrotum for a 4 month, no history of trauma, physical examination revealed testis is enlarged 6 centimeter size, firm and non-tender. So testis size is increased 6 centimeter. Trans illumination negative. Why they are doing trans illumination test? To differentiate it from a cyst. And USG revealed solid circumscribed mass in a left testis. Regional nodes were not palpated, orchidectomy done, histopathology biopsy shows the cell, they are arranged in a nesting pattern separated by fibrous septa and lymphocyte. So we are dealing with a seminoma, right? Nesting pattern, fibrous septa, lymphocyte infiltration, and the size is 6 centimeter, very large in size, 2 to 6 centimeters. So it's a seminoma. What's your diagnosis? Seminoma. Discuss etiopathogenesis. We know that KIT mutation is seen. So that was a case of seminoma, right? Morphology of this condition. So now you can write down the morphology: gross and microscopic appearance. Grossly, it is a rubbery form solid tumor that is well demarcated from the normal testis. Sometimes 10 times enlargement could be seen, and microscopically it shows the well-defined cell border, lymphocytic infiltration, fibrous septa, and clear cytoplasm due to presence of glycogen, right? So this type of question can be asked. Mention the spread and prognosis. So prognosis is good. It is a radiosensitive. Spread is to the renal lymph node. So these are the references for my today's lecture, right? All right. So again, in a 1 or 2 minute, just have a quick recap. What is etiopathogenesis? Environmental factor, cryptorchidism, testicular dysgenesis syndrome, genetic predisposition in the form of isochromosome development, Klinefelter syndrome, or mutation in a KIT. They are the risk factor for development of testicular tumor. Usually how the testicular tumor is classified: so germ cell tumor, sex cord-stromal tumor, or gonadoblastoma. Gonadoblastoma contain both the elements of germ cell as well as sex cord-stromal, right? Which are the sex cord-stromal tumors? Sertoli, leyding cell tumor. Which are the germ cell tumors? They are the seminoma, seminoma, embryonal Yolk Sac tumor, choriocarcinoma, teratoma, like that of tumor. They are the germ cell tumors. The seminoma, the key feature is it is a rubbery, grossly form clear cytoplasm, right? Clear cytoplasm is because of presence of glycogen. Embryonal carcinoma, very aggressive, grossly variegated appearance because of presence of necrosis and hemorrhage, and they show a high degree of anaplasia. More pleomorphism, tumor giant cell can be seen. Yolk Sac tumor characteristically show Schiller-Dewar body. That particular and photomicrograph shows microcystic pattern. Yolk Sac tumor can present as a microcystic pattern. Teratoma means they are arising from more than one germ cell layer, and they contain more than one germ cell layer tissues like that of cartilage, smooth muscle, squamous epithelium, respiratory epithelium, like that of Choriocarcinoma. And the name itself suggests it contains syncytio and cytotrophoblast. Syncytotrophoblast are large multinucleated cell, while cytotrophoblast is small cell with clear cytoplasm, well-defined border. Sertoli cell present as a small nodule can show the arrangement in the form of trabecula, and they are usually benign. They are hormonally active, but leading cell tumor are hormonally active. They secrete estrogen, androgen, and so patient can present with gynecomastia as well. Spermatocytic tumor shows tripartite cell, large, intermediate, and small size cell. Clinical feature is dragging sensation and plainness, enlargement of testicular tumor. The main difference is that seminoma tumor usually shows one histology type. Prognosis is very good. They are radiosensitive, less aggressive, usually present in stage 1, so necrosis and hemorrhage is not present. While non-seminomatous tumor usually present in stage 2 and 3, it can metastatize, and via hematogenous route it can spread to multiple organs. The prognosis is very poor. Prognosis is bad. It is radio resistant. Radiotherapy will not work in a non-seminoma tumor, and they present with more than one histology types. Alright, what is importance of tumor marker to evaluate the testicular tumor burden? Monitoring the response to the therapy. These are the various tumor markers that can be detected in a blood in case of a testicular tumor because they are released in a blood. In a seminoma, HCG. In a teratoma and teratocarcinoma, AFP and SCG. In a Yolk Sac tumor, AFP. In a embryonal carcinoma, carcinoembryonic antigen. And in a choriocarcinoma, mark elevation of beta HCG. Alright, so that's all about the testicular tumor. Thank you very much. Thanks for listening, and we will be right back with a new video. Till then, take care and bye bye. Thank you very much. Thank you.